There we go. So first of all, hello and welcome to this webinar on ADHD, reducing the time to diagnosis for children and young people in London. Next slide, please. This session today is hosted by the 3 London academic health science networks. And that's by myself, Ellie Wharton for the Health Innovation Network for South London, and Lindsay.
Yes, sorry, I'm working 2 screens and it's more stressful than I thought. Yes, I'm Lindsay Shevlin and I work for UCL Partners.
And Lena.
Hi everyone, my name is Lena. I work for Imperial College Health Partners and I'm the ADHD program lead. Welcome.
Fantastic, and it's great to see so many many of you joining us today. Next slide, please, Lindsay. Yeah, such fantastic breadth that we are seeing. We know that there are about over 40 different organisations represented here in this session today, which is incredible. And that's a real range of different roles and different teams across London, which is great to see. So why are we here? Today is about improving the ADHD assessment offer for children and young people in London, specifically considering the use of an objective test as part of that assessment. So hopefully today we'll be able to share some examples with you of this in practice, as well as hearing from some experiences from a young person and a mother through this journey as well. So we're going to start off with an introduction and welcome from myself and Lindsay, and then we will introduce Dr. Julie Clark, who is the National Clinical Lead for Focus ADHD, this programme, as well as a community paediatrician in the Midlands. Then we'll hand over to Dr. Nicola Reynolds, who will talk a little bit more about the experience of implementing an objective test, QbTest, into practice. Then we'll hear a short clip of a young man called Ollie about his experience of getting an ADHD diagnosis, and then from Jodie about her experience of being a mother through this journey. We will have question and answer sessions at the end of this session, so please use the Q&A function at the bottom of your screen to send your questions in throughout the session, and we'll be ready to answer those at the end. Next slide, please. So who are we? We are the Academic Health Science Network. So there are 15 of us across England, and we were established in 2013, and essentially with a specific remit of speeding up the best in health and care. We're commissioned by NHS England and NHS Improvement, and this is where all this work started. Was back in 2017, our colleagues in the East Midlands started having conversations about ADHD assessment. Next slide. So why are we talking about ADHD assessment? I won't linger too long on this because I'm sure you're all really familiar, but 1 in 20 school-aged children are affected by ADHD. There is real variation in terms of the referral criteria, diagnosis process and general provision across the country. And on average, children wait up to 2 years to obtain an accurate diagnosis. And that's a really long time for any young person. Next slide, please. So what we're hoping to do today is improve that ADHD assessment for children and young people in London. And for us, that's rooted in the use of an objective test as part of that assessment. We know, and it's well evidenced now, that that can help negate some of the challenges as part of this process. Over to you, Lindsay.
Thank you, Ellie, for that introduction. Next slide. So why QbTest? So the QbTest is the only objective testing system that simultaneously measures all 3 core components: attention, impulsivity, and motor activity. The performance of each patient is compared to an age and gender matched normative control group. It's important to note what it is not. It is not a standalone diagnostic, and it's not an instrument to replace clinical judgment. As you can see, we have a lot of evidence regarding this. Research-wise, there's 20+ publications, including a systematic review. University of Nottingham have undertaken research and published 3 independent publications. jump a slide. RCT all had QbT assessments, but half of all the results withheld. We have audited with and without QbTest, and there's been a study of acceptability amongst clinicians. On top of these two research parameters, we've also undertaken other UK studies, including Medway, Stockport, Blackpool and Salford. As you can see on the right-hand side, objective tests that measure 3 components of ADHD can help to streamline care pathways, increase in decisions made within 6 months, reduction in numbers of appointments, improved confidence and acceptability amongst clinicians, efficiency savings, and families welcome the use of technology for assessment. So there was a real-world demonstrator undertaken across 3 trusts, 7 clinics over 12 months in 2017, and over 1,200 children were assessed. We saw a reduction of 5 months from assessment to diagnosis time. This was the median. 1 appointment fewer to make a diagnostic decision. 20 to 33% clinical time was released. 94% of clinicians reported a greater understanding of patients' symptoms, and 85% of patients found the QbTest results helpful. On top of that, there was an £84,460 return on investment, which represents a £3.37 saving on every £1 spent. So enough of me. I'm going to hand over to Dr. Julie Clark, who is going to give an overview of understanding the application, objective testing in ADHD. Julie, are you on the call?
I am, yes, I'm here.
Brilliant. I'll move on to the next slide.
Okay, lovely. Thank you very much for having me to speak to you today. My journey with QB testing started with the AQUA trial, which is the Nottingham University trial back in 2014. So I've been a massive fan ever since that moment, and I'm on the Focus ADHD rollout programme to try and help clinicians to sort of unpick where there are reservations and to answer any questions. So I'm going to rattle through my presentation because a lot of it will probably you want to have time for questions and answers. But before we had QbTest in Lincolnshire, I think it's probably typical of most services, there was a huge rapid rise in demand and we just couldn't keep up with the capacity. We, as a community paediatric team in Lincolnshire, we were actually commissioned to provide all ADHD assessments. So we didn't just have the simple ones. I think there's a concept that sometimes community paediatrics see the easy ones and can see the hard ones, but in Lincolnshire, we saw them all. We didn't have a skill mix or a team, so we were just a team of doctors, which was really expensive. We didn't have a coordinated or robust admin service or support, so frequently we were finding ourselves coming to a first appointment with missing, insufficient or contradictory information from schools or from parents, that we just couldn't reach a diagnostic conclusion at the first or second appointments. Our job planning, I'm sure like lots of clinicians, became really robust and they didn't want us to spend any time travelling around or spending times in schools because that didn't seem to be good, effective use of our time. And we used to use the school nursing teams to help with school observations, but they were recommissioned in a different way and were no longer able to support us. So we were really dependent upon clinical history and just the school information, which were standardised questionnaires I'm sure we're all familiar with, Connors, etc. But it was very subjective and nothing had changed in years. And with the information about ADHD and indeed autism spectrum disorder, parents often came with a preconceived idea of what their child had as a problem. And it led to a lot of frustration, both from clinicians and parents. Next slide, please. So what were the limitations? Well, there was a high possibility of us drawing the wrong conclusion, whether missing the diagnosis or over-diagnosing. And I think we can all, in a very straightforward, very clear clinical case of ADHD, make a very quick decision about the child that does have ADHD, but the child that doesn't have ADHD, it took very much longer to evidence the fact that that wasn't the case. And it was frustrating for parents. So they may have come back to 2 or 3 appointments, often months apart, and we were still not in a position to be able to help them. So it led to a lot of challenges on diagnosis, second opinions, complaints. We had long waiting lists. Everybody was finding it all quite stressful. Sometimes we put children on the wrong treatment plans, or we weren't then signposting children to appropriate services that needed to be involved to help support these children and families. Next slide, please. So there was a definite case for change. There was no doubt about it. We know we have a limited workforce. Actually, recruiting into community paediatrics is quite difficult still. And there were lots of national policies being published that saying we need to improve our access to services, mental health services particularly. And even now, nationally, when I speak to other areas and other trusts across the country, there's a huge variation in the types of pathways that children go on. They're mainly subjective, they're often multiple sources of information, they're lengthy, they're inefficient, and there's high costs associated with that. And we really have evidence, as Lindsay said, we have a lot of evidence now to support the fact that we need to be using something more objective. Next slide, please. So what improves if you add a QbTest to an ADHD assessment? It definitely improves the speed, the quality, and the diagnostic certainty. Why are we the only service that hasn't been able to embrace new technology? Other aspects of medicine have definitely moved along with the times, and we seem stuck in the dark ages. There are huge cost benefits and additional clinical capacity to released. I mean, we don't sit around doing nothing because we've got a QbTest in our pathway. It just means that we can move these children through our assessments in much more timely fashion. And any cost efficiency savings you get are actually realised in the same financial year. So you don't really have to invest to get your benefits back. Patients love it. They absolutely love the visual representation that you can get of the symptoms of ADHD, and it definitely improves clinical confidence. And it certainly allows us to promptly discharge and signpost those children who don't have ADHD. And as Lindsay said, it completely mitigates for birth date and gender bias. You're probably all aware that we get a lot of August birthday boys who are slightly immature for their year group, and or no girls referred, and this allows us to sort of look at those clinical symptoms and completely compare them according to a child of exactly the same sex and date of birth. Next slide, please. So it really is really valuable for certain children, but particularly girls where ADHD is often missed. Unfortunately, girls are still under-referred. So even when we see them and diagnose them, there are a lot that are being missed. And it's quite clear now from adult referral patterns that women have as much ADHD as men, but we're not picking it up in the younger age groups. Like say boys with an August birthday, children at secondary school, everybody's got a different opinion about a child dependent upon the subject that they're teaching, the type of way in which they are presented with the learning materials. Children who have specific learning difficulties will often look inattentive, and it's really helpful to sort of unravel which ones actually have ADD or ADHD to those that have more got a learning difficulty. Children who are very anxious, particularly those with ASD, it's really easy to help identify those children that have ADHD as well. I'm sure we've all got separated families where parents have completely different opinions. These sort of areas of conflict can be really difficult to resolve without something objective to really show parents so that they can understand why we're making a diagnosis or why we're not. Children in the care system who don't have parents who can give us a good history, children with attachment difficulties, in summary, just about everybody. Next slide, please. So just looking at the studies, as you say, we've got lots of studies now, but there's absolutely no doubt that it improves your quality of assessment if you add in a QbTest to the already standard assessment rating scales, etc. Next slide, please. So much so that you would not change your diagnosis half as much, or not even more than that. So with a QbTest, you reduce your likelihood of getting the diagnosis wrong down from 20% to 2%. Next slide, please. And it is really lovely to sort of be able to share a parent the sort of before and, next slide, please, and after QbTest. So this this is a really good visual representation of how you can say, look, there's your diagnosis and this is your child on treatment. Next slide, please. And if you haven't got ADHD, it does, even with the QbTest, help to inform you of what else you need to be looking for. Next slide, please. So why do we put it early in our assessment pathway? So as soon as a child's accepted at a single point of entry into our service and considered to have symptoms consistent with ADHD over the age of 6, we put them on the ADHD assessment pathway. And the first thing that they do is they come for a QbTest. We calculated our capacity, which means that everybody gets a QbTest within a month of being booked into our service. And it gives immediate engagement. They have to wait a lot longer to come see the doctor, but at least the parents know that they've been accepted and they're on that assessment pathway. At the time they attend for their QbTest, we sit the parent down and we make them fill in all their relevant questionnaires, a very detailed parental questionnaire, their parental Connors questionnaire, strengths and difficulties, Cambridge Autism Quotient questionnaire, and we give them their school questionnaires that they have the responsibility for taking into school and for returning back to us within 2 weeks. And until we get that information back, we don't appoint. So the first time a doctor sees a patient for their first appointment, everything you could possibly want in terms of information gathering is already available. And we've got an electronic clinical system. We use System 1, so it's all uploaded onto that. And it does mean at the first assessment with the doctor, you can almost certainly make an accurate decision as to whether ADHD is the diagnosis. You may well find there are other comorbidities that need further assessing, but at least you can start to move forward on the treatment options or signposting if appropriate. And it does give parents a lot more confidence in your diagnosis. And aside from that is because we employed healthcare support workers to perform to conduct our QbTests. I think that our management team recognised the benefit of skill mixing within a team. And so as a knock-on benefit, we've now got ADHD nurses in our service as well. Next slide, please. So summary, it's easy, it's quick, and it can easily be integrated into any care pathway. You don't have to completely redesign your pathway. It supports a clinical decision, gets us to the diagnosis a lot quicker, helps us to manage our resources, improves the patient throughput, and helps with psychoeducation of the parent and the child, and saves us money. So it's a win-win, really. Next slide, please. I think that's me done. So I think we're going to do questions at the end, so I'll hand over to my colleague now.
Thank you so much, Julie. And we're getting quite a few questions coming through in the chat, which is fantastic. And we'll come back to those at the end. So without further ado, I'd like to introduce Dr. Nicola Reynolds, who is my colleague at the Health Innovation Network. She's our Deputy Clinical Director in Mental Health, as well as Principal Clinical Psychologist at Oxley's and Clinical Lead for the Integrated Neurodevelopmental Service. Now, I'm sure Nicola will tell you very shortly that they implemented QbTest about a year ago now. So really looking forward to hearing from Nicola and what she's able to share. Nicola, are you able to unmute and come on video?
It's not letting me start my video, saying the host. Oh, here we go, I got it.
Perfect, over to you.
Okay, so can you hear me? Still saying I can't turn my video on. I don't know.
You're all good, you're all
We
good.
can hear you,
okay,
yeah.
Great. Right, yeah, so thank you for the introduction. So as Ellie said, I'm the Principal Clinical Psychologist. I'm also the Clinical Lead for the Integrated Neurodevelopmental team in Oxley. So that's the pathways for ADHD and autism, and I lead on the Greenwich Borough. Next slide, please. So the ADHD team sees children aged 5 to 18 who have a Greenwich GP and who are presenting with difficulties that might indicate ADHD, but often there's concerns about comorbid autism spectrum disorders or queries about learning difficulties. We're a multidisciplinary team that's made up of psychiatrists, ADHD nurses, we've got an advanced pharmacist, and then there's myself, who's a psychologist. We're quite unique in that we're a standalone service, so we're not part of CAMS or community paediatrics. Traditionally, ADHD tends to sit in one of those services or sits across both. So we're a sort of standalone service. So our colleagues in CAMS and community paediatrics also see some children with ADHD, but we see the majority of them. And we piloted the QbTest sort of around October, November time last year. The main sort of reason for doing that was, like many services, we had seen a significant increase in referrals over the last sort of 5 years, but no increase in resource, within the team. So at one point, our wait lists had kind of got up to 2 years. And we had real problems with recruitment. So we did have a little bit of additional funding to try and help address the wait lists, but we just couldn't recruit into the posts that we were advertising for. So we had tried to advertise for psychologists, we tried advertising for a psychiatrist, and we just found we couldn't get people in post. So we had this funding to sit in there, but not able to make any use of it to really address our wait times. We were also working on a broader pathway redesign for autism and ADHD anyway, looking at how we could integrate those pathways a bit more closely, how we could streamline things. So the QB pilot was sort of in the context of a broader piece of service redesign. And we are aware that with the QbTest, it could be administered by a sort of healthcare assistant. So looking at the funding that we had, we realised that we would be able to sort of get more initial assessments done by recruiting a healthcare assistant to administer the QB, rather than sort of recruiting a doctor or a psychologist who's sort of much more sort of expensive resource, and perhaps wouldn't be able to yield the same number of initial assessments that we could get from a healthcare assistant in the QbTest. Next slide, please. So we are sort of at the end of the first year of the QbTest, and I have to say it's just gone really, really well. Trying to sort of embed any new thing into a pathway is often quite a challenge. Doing it sort of during an ongoing sort of pandemic and lockdown, I would certainly have expected it to be a lot more challenging than it has been, but it's actually gone really smoothly. And it is something that can be sort of embedded into your pathway quite easily. So I've got some sort of figures here from just sort of looking at last year. So when we started, sort of June 2020, we had about sort of 300 children sat on our wait list, and we tend to get about 24, 25 new referrals every month as well. So that kind of wait list number wasn't really coming down. Because we didn't have the capacity to see the number of new referrals we were getting, let alone try and clear the additional numbers that we needed to clear in order to bring that backlog down. And as I say, you'll see that from November, we started to implement the QB. And we started off quite small initially, whilst we were just seeing how it fitted within the pathway and tweaking anything that we needed to tweak in terms of the process. But by sort of February, healthcare assistant was in post full time. There was quite a significant increase in the number of QBs that we were doing. So, for the first time in a really long time, the number of initial assessments that we were doing were not only, matching the number of referrals we were getting, they were actually exceeding it. So we actually could start to clear that backlog of children that were waiting. And as of October, we'd reduced that figure from sort of almost 300 children to, I think sort of it was about 199, so it was just under 200. And our wait time has decreased significantly. So we'd got our wait time down to about sort of 45 weeks in October, and as it stands at the moment, it's about sort of 18 weeks. So there's been a significant decrease in that wait time for that first appointment. And we use it right at the beginning of our pathway, as Julie said. So what we do when a referral comes in, a member of the team looks at it just to see whether it is an appropriate referral. If it is, then our admin team or our single point of access will send out the Connors questionnaires to the parent and the school. We use the electronic Connors, so they're sent a link to that. We also send out a sort of full questionnaire that we have developed ourselves, which gathers much more kind of qualitative information. And then we've also developed a parental history questionnaire that asks about things like the child's early development and medical history, family background, social sort of background, but also some more sort of qualitative kind of questions about ADHD, but also social communication and interaction, because we know that ADHD and ASD can often be kind of comorbid. So all those questionnaires are sent out, then the young person is booked in for their QbTest. They come into clinic and have the QbTest with our healthcare assistant, and then the team will look at all of that information, so sort of do an initial screening. And what we've found by having that additional bit of information from the QB alongside all of the other stuff is you usually get a pretty good impression about whether a young person is meeting the diagnostic criteria or not, and also whether they whether there's any indicators of sort of potential comorbidity like autism spectrum disorder. So what it's enabled us to do is to develop a bit of a stepped care approach to our assessments. So whereas before, everybody had sort of an hour and a half long appointment with the psychiatrist or the psychologist and the nurses, we can now take a slightly different approach. So for those where we can see that there possibly is some comorbidity or there's some complexity, they would still have the slightly longer appointment. But for those where it's looking much more clear cut that they either do or they don't, and there's no sort of sense of kind of comorbidity and other things, they can have a sort of slightly shorter appointment. So it's enabled us to do more appointments with the same number of staff. So when we first started doing the QB, I mean, one of our senior managers asked, is it really going to make a difference, because you do tend to diagnose a lot of your children in one appointment as it is. But actually it has made a difference, because although we're still generally making the decision within one appointment, for a lot of children now that appointment's much briefer, so we're able to do more appointments. Next slide, please. So in terms of the benefits, I mean, a lot of the benefits that we've noticed are the same ones that Julie mentioned in her presentation. As I say, it's certainly made the whole process more efficient. Children where it's much more clear cut can be, moved through the pathway much more quickly, but also children that have got potential comorbidities are getting identified much earlier on in the pathway. So that enables us to have a sort of more integrated approach. Children that are presenting with ADHD and sort of possible autism spectrum, we can now sort of combine those assessments a bit more, rather than what we've had in the past, where a child waits for a really long time for their ADHD assessment. You do the assessment, and during the assessment you identify they might have autism spectrum as well, and then they have to get referred on somewhere else where they wait for another assessment. We're more able to sort of bring those two assessments together and sort of start to do the diagnostic history taking for ASD at the same time as doing the ADHD assessment. Certainly, staff, I think, feel that the QbTest just helps them to feel more confident, that feel that the sort of assessment is more robust. We've always had to kind of rely very much on sort of subjective reports from teachers and parents, and although the Connors are obviously very standardised, but they're inherently quite subjective, because they'll depend, it depends on who's filling them out and what their sort of point of view is. And so in situations where there's differences of opinion, with parents reporting, perhaps a very different picture to what the school are reporting, it gives us another bit of information that we can feel a bit more confident about because of the objective nature of it. And it means that we don't have to try and do things like school visits and school observations, which we've done in the past, and they're quite time intensive. To do an hour-long school observation would take out most of your morning or most of your afternoon by the time you'd factored in travel and things. So we find that there's less kind of challenge and comeback. since we've been using the QB. So even when we have had situations where perhaps a school hasn't reported that many concerns, but the parents are, and then we've observed the child in clinic whilst they're doing the QB, and their QB test has come out scoring really high as well. There have been times where we've given a diagnosis, even though the school might have not reported that many concerns, and schools that have not really challenged that in a way they might have done previously when we didn't have the sort of QB test to sort of help further inform that assessment. So it does help us to have kind of conversations around diagnostic decisions, and particularly where you're not given a diagnosis. In the past, that's often been quite a challenging conversation, particularly if a family are very invested in the idea that their child may have ADHD. So having that objective data just helps to sort of support those conversations, and I think it helps parents to feel a bit clearer about the rationale for the decision that's being made. One of the ways that the QB test can also be used is to look at sort of the impact of medication, so monitoring the effectiveness of medication. We haven't used the QB test in that way yet in our team, because the focus of the pilot was around reducing the wait times and sort of streamlining the diagnostic bit of the pathway. But now that we have reduced our wait times to a much more sort of acceptable level, they're going forward sort of this year coming, our plan is to start looking at how we can use the QB to look at outcomes, because that's something that we've always, I think, found a bit difficult as a team. Once a child has started on medication, how do we kind of capture some good sort of data about their outcomes and the effectiveness of medication. And we do have quite a few children where medication doesn't seem to be helpful. Parents and schools are often requesting that medication is increased or changed, and we might not always feel that clinically that's the answer. We might feel that there's other things that systemically might need to be addressed, but at the moment it can be hard to have those conversations without having some objective data there to be able to show, actually, this tells us that medication does seem to be effective. Maybe some of these other concerns need to be thought about in a different kind of way. I think in terms of challenges, the main one has been that sort of demand and capacity further along the pathway. So obviously by increasing the number of initial assessments and diagnosis, it does mean we've now got a higher number of children waiting to start medication. So I think that's something if you're planning to implement the QbTest, sort of bear in mind. And then sort of the business case bit was, I put it as a challenge. It wasn't a challenge that much in that, the QB do have a sort of budget impact model that they can share with you to help you map out, the cost and benefits and so on. I think it was more, I suppose, a challenge of just pulling it together and those initial conversations and trying to sort of work out where, what the benefit would be. Next slide. So I guess just sort of top tips if people are thinking about implementing it. I mean, just getting that engagement with senior managers and your business support office really early on. So our business support office did a lot of work around modelling capacity and demand and caseload projections and things. There's quite a bit of preparation, doing things like filling out your, DPIAs. We had to sort of present to our medical devices committee to get sign off. We did quite a bit of process mapping, so looking at how, how the QB was going to be embedded into the pathway, what impact that would have on our admin staff, and just working out what it was going to look like. And we were liaising with our IT team and our sort of chief clinical information officer. So, but it was really, really valuable to do all of that groundwork before, because once we were then ready to go with the QB, the process was actually really, really smooth. And I say we started quite small. We used that sort of quality improvement framework with PDSA cycles. So the first week we just did it with one child, looked whether anything needed tweaking, and then sort of the next week did it with a few more children, and just sort of gradually kind of made sure that we were, smoothing out the process before we kind of went onto our whole pathway.
Thank you, Nicola, and thank you, Julie. We have been getting questions in the chat, but we're going to answer them at the end. And also just to confirm that we will be sending copies of the slide and a recording of this webinar around. I'm now going to hand over to Ellie, who will share a video of someone who's actually gone through the QbTest process. at the age of 16, and following on from that, we will hear from a parent. So we'll get a good overview of the QbTest impact on children and families.
Well, when I was younger, I was diagnosed with dyspraxia, and that kind of branched off into dyslexia as well. But after speaking with both my first schools, so my primary and secondary schools, about my concentration and my focus and fidgeting, we really thought there was something else, but we couldn't quite put a finger on it. And then about 2-3 years ago, my brother got diagnosed with ADHD, and obviously because it runs through families, we thought that we may as well check to see if I may have it. He was much more of a kind of his outbursts of energy more be like jumping up and down, running about, whereas mine were mostly fidgety. Like I'm fidgeting right now, I can't sit still for, I would say, longer than 10 seconds. But we never really thought that I would have ADHD, because you would look at my brother and say, oh, he's running around, jumping up and down, this and that. And you think, oh, fair enough, he's pretty got ADHD, but you can't really figure out, you can't really see my little hand movements, my little leg taps. It's quite hidden. This was introduced to me for my second appointment at Oxley's. They told me about a new test they were willing to take if I was happy to do so. And obviously, I thought, why not? I'd be happy to do that. So about a month later, after they told me, they brought me into a room and sat me down for about half an hour to an hour. I was told that I'll be tracked on my head to track my movement, and I'd have to click on, I think it was on shapes that were the same colour. And at first, I really thought there's no point to this test. I was really confused about what it was trying to get out of me, but I did it anyway. And then the person that was doing the assessment, he said that I would have to wait about 3 weeks to get my results back. I waited, and then I got a Zoom call from the person that did the test, just explaining what happened, where I was in this kind of out of everyone else in the country. And there was a graph with my head movement on it that was controlled by a motion sensor. And very funny, because we saw the average kind of head movement for a normal 16-year-old boy my age. So that was just like a little black dot in the center. But then we saw mine, it was like a big scribble like you gave a crayon to a 4-year-old. And we thought that was hilarious, but at the same time, very disturbing. That was good. Before I got diagnosed, I'd have to say to my teachers, look, do you mind if I go to the toilet every 10 minutes, 20 minutes a lesson, just to go run up and down the hall quickly, so I could sit down and concentrate for about 10 minutes. But now I can speak to my teacher and say, oh, look, I've just been diagnosed, and they understand completely. So I never really have to ask to go to the toilet. So my peers aren't looking at me going, what is wrong with this boy's bladder? So I just ask my teachers now, look, do you mind if I go run up and down the hall quickly? Then I'll be able to come back down, concentrate on your lesson, and actually work. So they always say yes. And that has really, really helped me. Before I was diagnosed, and before I did the QbTest, it was really, really hard to explain my symptoms and what I was feeling and why I couldn't do this and that. And when the results came back, it was a direct correlation between what I was thinking and what the test actually showed us. And that really just helped me explain to my parents that this is what's going on with me and the ways I think I'll be able to help myself. She's really found it quite funny, as well as my dad as well. because they always told me that, oh no, there's nothing wrong with you, you just need to work harder. And when we got our results back, it was kind of a nervous laughter because she'd realised, oh no, I've been wrong all these years. So I thought it was quite good. I've kind of learned to accept it. I've learned to understand there's a lot I can do. I just have to put my mind to it. So now I'm a half term and I've got a test coming up, so I have to revise for that. And I found what works for me is if I sit here for 20 minutes, 20-minute periods, concentrate hard, and run around for 10 minutes and sit back down, I'll be able to work perfectly. But I just realised that I need just a bit more extra time to complete the same tasks that other people do. And there's nothing really wrong with that in the slightest. I just find it a bit annoying from time to time, but at the same time, there's nothing I can really do. So I've learned to accept it. Well, my assessment and everything ran really, really smoothly. I can't remember any kind of hiccups there were in the slightest using the QbTest. It was the test, when I was doing the test, I didn't really feel like a subject, if that makes any sense. Like I was just being monitored and monitored and monitored. It was really quite simple and straightforward, yet it really showed my kind of feelings and what I was experiencing. So overall, I just think I think it was very good. I really didn't enjoy it per se, but it was a very accurate representation of what I was feeling.
Thank you, Ellie, for sharing Ollie's video. I'm going to speak to Jodie, who I'm sure completely understands where Ollie is coming from. Jodie, able to, thank you. Jodie's a parent, and then if you could talk until 12:50, 7 minutes, that would be great. Giving an overview of the impact of your child's diagnosis with ADHD and his route to diagnosis.
Oh, thank you. Hello, everybody, and thank you for inviting me. Our route to diagnosis was slightly different to what's been discussed today. So we had a referral to CAMHS from the school. That wasn't until Ben, who is my youngest, was in year 4, so around 8-9 years of age. He was moved schools because they weren't able to deal with his behaviour and weren't supporting him, so he wasn't progressing. So the referral went to CAMHS. We didn't have the QbTest straight away. We had appointments with the clinician to discuss what difficulties there were. Sorry, in 1 second, you're going to hear the ice cream man. Sorry about that.
I'll have a 99, please.
Yeah. Anyone else? Okay. Yeah, so we had the Connors questionnaires and we had a few meetings with the clinician first before the QbTest was discussed. So it was explained to us, we were able to go away, look at videos, really do a bit of research into it. It was actually really, really helpful for us as a family because Ben didn't engage very well with the clinician. He didn't want to talk to them. He would just stay silent in the background. So when we explained the test, it was something sort of tangible for him to get his head around, that it's not just all in your head. It's not all of these words that you're hearing about behaviour and can't sit still. There's probably actually something going on. So for us to actually then have this physical test and then see the actual results, which as well for my husband, he can't sit and look through words and pages of diagnoses and things like that. I love words, I love research. He's not interested, his brain can't work like that. And for him to actually see the results himself and see what happened in the test was really helpful for him to understand. Now with Ben, it wasn't 100% conclusive if he'd have just had that QbTest. So we did need those appointments. We needed the Connors questionnaires as well. But when we finally got the diagnosis, when I tell you what a relief and how much it changed our lives, truly, I'm not sure I can quite put into words, but I will try. For Ben, it was an understanding of himself. He knew he was different at that age. He could see that he was behaving in a different way. He couldn't understand why he was like he was. So to actually explain it to him and to get the books and then to explain it to his teachers, and then they could use different strategies to support him. And then it wasn't all about behaviour. It was about all the positive things he was doing and how to manage that behaviour, like brain breaks and rewards for him wouldn't work. It'd work for a month and then they'd have to switch it up and do something else. But then they understood that, and they understood why they had to do that. The negativity that comes from a child that behaves in a way that isn't typical to most children, his self-esteem was so low and his confidence. We didn't understand it either as parents. We were blamed for his behaviour. So we had to deal with that shame as well. But for Ben, he now recognises and he accepts who he is, and he knows that it's not something that he needs to change. He knows that it's not a choice that he's making all the time with his behaviour. He can't help it. And when we were looking at senior schools, because he's just gone to senior school, we then were able to speak to the Senkos and things like that and just see how they treated and looked at behaviour. Were they going to be accepting of him? Was he going to get punished for things that he couldn't control? Would they allow him to move around? And one of the big things for us with Ben is his actual awareness now of the types of things that he does and types of things that he needs, such as he needs these breaks, these movement breaks. And we said to him, well, just ask to go to the toilet, as Ollie was saying. Now, as parents, we didn't understand that, you know, putting your hand up, going to the toilet all the time, every sort of 10 minutes, your peers are going to see that. They're going to notice, they could say something. And Ben himself said, well, if I go to the toilet, I'm just going to wander around. I won't go to the toilet. I'll just walk around. So it was like a light bulb moment. He actually understands who he is. And having this diagnosis helps us all to support him. And with our families as well. You know, they didn't understand it. It was a relatively new thing to have this diagnosis of ADHD. You're just thinking it's naughty children. So the whole family then can come together and support. For us, it's about educating the schools, peers, family. I work in education, so it's a big thing for me to be able to speak to teachers and our SEND department about my point of view and my child's point of view, because it's completely different to your points of view and how you see it. For us, it was life-changing. Like I said, we were blamed quite a lot for our child's behaviour. We thought it was us. And to actually be told and to have that in writing and to see that test, it was like the guilt was gone and we were able to parent relatively guilt-free. I mean, I know as parents we feel that all the time, but the confidence that I've got now in myself as a parent to be able to parent him, and I treat him not as a typical child, which are what I was trying to do, and thought, why can't you just do this and why can't you do that? I treat him as a child with ADHD. He has ASD as well. That's the child he is. So I make allowances. We can't do typical parenting. We take him to clubs that are suitable for children with ADHD so that he can be around children just like himself. There's no embarrassment. There's no difference. And for us as parents, we can get support, because if you're a parent of a child that has got a diagnosis such as this, it's tough. You feel like you're always fighting a battle. So you need other people that understand that, and the only other people that will understand that is parents like you. So to receive this diagnosis, to have that test, to us was actually life-changing. And more importantly, it means that Ben gets the support he needs from us and from people around him.
Thank you so much, Jodie. Thanks for taking the time of your day today and also sharing your very valuable and insightful experience with us today. Very interesting to hear. We now have a bit of time to answer your many questions. Thank you so much for sending them through in the chat and in the Q&A section as well. We have our panel here today to answer your questions. We have Nicola and Julie here with us, who you have already met, and we also have Alec Barber here and Sean Hopkins, who both work for QbTech and will be able to answer your questions. And I would like to kick us off with some of the most frequently asked questions. And maybe Sean and Alec, you can answer the first one. I think it's been replied to in the chat, but maybe just to repeat for everyone. So which age groups can QbTest be used for, and can it be used for young adults? And what is the upper age limit?
So the QbTest can be used for any patients between the ages of 6 and 60. And the reason for that is that when receiving a report after the QbTest is taken, we compare those results with a normative group of the same age and gender. And so we have that normative data from those ages, so 6 to 60.
Great, thank you, Alec. Very helpful. On to the next question, which I think has been asked quite frequently as well, which is, can QbTest be used for children with a learning disability and other ADHD concerns? And maybe that might be a question for you, Julie or Nicola.
Yes, so QbTest is divided into two. They for the younger age group and for those over the age of 11. So there are some children who have significant learning difficulties that would not be able to complete a QbTest. So if you've got severe learning difficulties, no, it wouldn't be appropriate. But if you've got mild or specific learning difficulties, then this test is really easy to do, and most of the children definitely understand it. There's a video that they see. There are then instruction cards that they can go through, and then they have 3 practice runs. And so long as they can get their commission or omission error better than above 30%, if you see what I mean, or below 30%, the error is not greater than 30%, then you can conduct the test. For those children that come along to the QbTest and then you can't conduct the test, in itself, that's really informative. So we always say to parents, don't worry if they can't do it. It's very informative, the fact that they can't do it. And the children that perhaps we find the most difficulty with are those that are highly anxious. So sometimes we take a lot longer to prepare those children to come into the test. So the test itself is 15 or 20 minutes long, but you need a bit of preparation time. You need to set it up. They need the height, weight and blood pressure doing before they come into the clinic, or they need the height and weight doing. You need to put some basic details into the computer. And so we allow about a 40-minute appointment. We make sure the child's settled, gone to the toilet, not going to jig because they need, talking about bladders, assumedly. That's a common theme of today. But yeah, so it's about a sort of 15 to 20-minute activity, but we allow about a 40-minute appointment. I think there was somebody that said, isn't it expensive, but it's a whole lot cheaper to have a healthcare support worker and a QbTest than it is a doctor's appointment. And as you say, saving time on clinical appointment time offsets it very easily. So the efficiencies, cost efficiencies are very evident.
Great, thank you, Julie. And we have had 2 questions in relation to that, which are, can the test be used for children with a visual impairment? And are parents advised to kind of think about their child not wearing reflective clothing, which might affect the QbTest scoring?
Do you want me to answer?
Yes,
it's very obvious when children are wearing reflective clothing. They come in and the camera just goes crazy. So yeah, this is quite a theme. So we always make sure that you just wear simple dark clothing. Most of the reflective bits on clothing are on outer clothing like coats. So generally speaking, that can be addressed, and it's very clear at the beginning of the test that you're getting extra reflections. So, and if there are reflections or the head camera or the head receptor is lost during the recording, it's very clear on the tracing, and that there's a warning triangle that comes on that highlights you to it. So you don't get inaccurate hyperactivity when you've seen a child sort of moving around. So it's very clear. And if you ever get a QB recording that you just can't interpret, you can book an appointment with QB Tech and they'll talk you through it, and they can sometimes clean up a recording. So if for argument's sake there are some reflections or there were some distractions, they can actually take that little part out and still give you an accurate sort of idea of what the child's activity was throughout. What was the second part to that question? I can't remember.
It's about visual impairments.
Exactly.
Oh yeah, I mean, if you've got a significant visual impairment, then no, you wouldn't be able to do it. You do need to be able to see the screen, but the screen is a normal laptop screen and the signs on the screen are quite large. So you'd have to have a very significant visual impairment that would prevent you from doing it, but you'd have to check with peripatetic teacher as to what print size the child's able to interpret. But for the greatest majority, a simple visual impairment that corrects with spectacles isn't a problem at all.
Great, thank you, Julie. And I think another question, which might be one for you, Nicola, since you've kind of fed back about your experience of setting up QbTest in your service as well. What qualifications do you need to deliver a QbTest? What professionals are usually doing this, carrying this out in your service?
So it's a healthcare assistant, so band 3. So yeah, healthcare assistant psychologist is fine. You have training from the QbTest team. They do sort of installation trainings right at the beginning. They came out and trained the team in the administration, and then the clinicians who do the diagnosis, like psychiatrists and psychologists and nurses, were then trained in the interpretation. So we wouldn't expect a healthcare assistant to be doing the interpretation. They just do the administration. Really straightforward, simple to administer on a laptop. So you don't need to have, you know, sort of really qualified members of staff.
Great, thank you, Nicola. Very helpful to understand. And I would like to ask a question around the average costs, Alec and Sean. So what's the average cost for the technology? Are you able to give some idea of the cost to implement, buy the equipment, and the onwards cost? Just kind of what's coming up if a service wants to implement QbTest.
Yeah, of course, and all services will be different. And so to that, I'd say if anyone's really interested in learning a bit more about their specific service, we can arrange to do a business impact model with them to show them really what can be done. But the average costing per year would be around 12,000 on average. It's organised in such a way that you'll have a license fee, and on top of that license fee, you'll have individual test costs, which we do provide discounts to, depending on how many are done. All the equipment is provided in the license fee, so there's no additional costs to any of that. But if people are interested, if you are to put your contact details, email in the chat box, we can reach out to organise something.
Great, thank you, Alec. I'll hand over to Ellie to wrap up the session for today.
Yeah, thank you so much. Thank you so much to all our panelists today and all of you for joining us and sending in such great questions. Just to say that we will follow up with all of those that were able to attend today and share the slides, share this recording, and be able to answer any of the questions that we haven't managed to get to today. But just again to say thank you so much to everyone who's contributed to today, and I hope you found it an interesting conversation. Have a lovely afternoon, everyone.
Thank you. Take care.
For joining, everyone. Bye.